Imagine going to the doctor because every time you sit down or ride a bike or even just take a walk, you're just in this state of constant physical agony.
Right.
And now imagine that up to like 84% of a specific demographic has this exact same condition, but only 7% of them are actually receiving any treatment for it.
I mean, it sounds like a public health crisis that would be on the front page of every single newspaper, right? But instead, the medical community and really society at large have just historically brushed this under the rug as, a normal part of getting older.
Yeah, exactly. Well, welcome to another deep dive. If you were listening to this, whether you're trying to support a partner or you're navigating your own health, or maybe you just want to understand how medical terminology can profoundly shape or honestly hinder treatment, you are definitely in the right place.
You really are.
Today, we've got a huge stack of clinical guidelines, NHS trust leaflets, and consensus statements from both the British Menopause Society and the British Society of Sexual Medicine. And our mission today is to answer one very specific question that causes an immense amount of confusion, which is vaginal dryness the same thing as atrophy, or this acronym you might have seen, GSM?
Right. And it is a really critical question to clarify because the short answer is no. They are fundamentally different concepts. To really picture what we're dissecting today, I want you to imagine looking at a cross-section of human tissue under a microscope, right? And you're watching these glowing data points track hormone receptors as they just sort of switch off one by one.
Wow. Okay.
Yeah, we're going to look way past the surface level complaints today and examine the actual structural cellular changes that are happening in the body.
Okay, let's unpack this because I think we need to start by pulling apart the vocabulary. Even in some of the clinical literature, these terms seem to get totally tangled up. So if someone goes to their doctor complaining of, quote-unquote, vaginal dryness, what is that term actually describing medically?
So in clinical terms, vaginal dryness is strictly a symptom.
Just a symptom.
Exactly. It's an experience that's reported by the patient. If we think about, say, a respiratory illness, right? A cough is a symptom of something much larger going on in the lungs.
Right. So is calling this condition vaginal dryness a bit like calling a severe chest infection just a cough?
That is the perfect analogy, yes. Dryness is the cough. It's one single manifestation, but unfortunately it's often where the conversation just stops. People assume it's merely a minor, maybe temporary lack of lubrication.
But then, you encounter the term vaginal atrophy or atrophic vaginitis in the medical texts. And that sounds significantly more serious than just needing to buy some lotion.
Right, because atrophy refers to the actual anatomical deterioration. So if dryness is the cough, atrophy is the chest infection.
Got it.
The sources define it as the physical thinning, drying, and inflammation of the vaginal walls. It's a structural breakdown of the tissue, and it's entirely driven by a lack of estrogen. So the tissue is literally changing its basic architecture.
Okay, so dryness is what you feel, but atrophy is the physical change that's actually causing it.
Exactly.
But even the word atrophy was deemed inadequate by the medical community a few years ago, wasn't it?
Yeah.
Our sources point to this major shift in 2014 regarding how doctors are actually supposed to talk about this.
Yeah, they did. So the International Society for the Study of Women's Sexual Health and the North American Menopause Society, they realized that diagnosing patients with vulvovaginal atrophy was leaving this massive blind spot.
How so?
Well, because that term only focuses on the genital tract. It completely ignores the lower urinary tract symptoms that almost always accompany these vaginal changes.
Oh, interesting.
Right. What's fascinating here is that they retired those old terms because they just didn't cover the full spectrum. So they introduced an umbrella term, Genitourinary Syndrome of Menopause, or GSM.
Genitourinary,
Yeah.
meaning it links the genitals and the urinary system together under like one single diagnosis?
Yes, because they stem from the exact same root cause, which is a postmenopausal hypoestrogenic state.
Okay, hypoestrogenic, so low estrogen.
Exactly. That's just the clinical way of saying the body's estrogen levels have dropped below the necessary threshold to maintain those specific tissues. GSM captures the entire regional impact of that hormone drop.
Okay, so if the root of this issue is an estrogen drop, I really want to understand how that actually triggers such a massive physical change. Because the sources refer to GSM as a silent epidemic, which implies something widespread and really destructive. What is actually happening down at the cellular level?
Well, we have to look at where the body actually places its estrogen receptors. They are just densely packed into the vagina, the urethra, the bladder trigone, which is the smooth region right at the base of the bladder, and that whole pelvic floor muscle network.
Okay.
That entire region basically relies on a constant, steady supply of estrogen just to function normally. When that fuel supply drops, the very first thing to go is the superficial epithelial cells,
Which are what exactly?
or the protective top layer of cells in the vagina. And according to the British Menopause Society, the volume of those superficial cells drops to less than 10% of their normal level.
Wait, less than 10%?
Yeah.
Oh, wow. No wonder you use the word atrophy. I mean, the tissue is practically disappearing at that point.
It really is. And it initiates the severe ecological collapse because those superficial cells, they have a very specific job. They release glycogen.
Okay, glycogen.
Right. And glycogen is the primary food source for lactobacilli.
Yeah.
Those are the healthy bacteria that basically keep the vaginal ecosystem acidic and, perfectly balanced.
So that entire protective acidic environment relies completely on that glycogen.
Yes. So when this estrogen drops, the cells vanish. Without the cells, there's no glycogen. Without the glycogen, the lactobacilli basically starve and die off.
Which changes the pH.
Exactly. As a result, the pH of the vagina actually rises above a 5. It shifts from being acidic to neutral.
And neutral is bad in this case.
Very bad. A neutral pH is basically an open invitation for commensal organisms. So bacteria that normally just live nearby in the gut, like E. coli, they can suddenly migrate in, thrive, and cause these terrible localized infections.
That makes so much sense. That explains the ecological side of it.
Yeah.
But the sources also detail these really severe structural changes. There's a term they use, hyalinization.
Yeah, hyalinization. So in a healthy estrogen-fueled vagina, the walls are corrugated. They have these folds called rugae, and they act almost like an accordion, allowing the tissue to stretch painlessly.
Like during sex or childbirth.
Right. And that elasticity comes from collagen. But without estrogen, the fibroblasts, which are the specific cells that manufacture that collagen, they just go completely dormant.
Oh, wow.
So without new collagen being made, the existing connective tissue starts to degrade. The fibers lose their structure and they clump together into this glassy kind of rigid mass. That is hyalinization. The tissue physically fuses together and those accordion folds completely smooth out.
So the tissue is losing its ability to stretch and it's becoming rigid.
Yeah.
Which would make it incredibly fragile, I imagine.
Very. It becomes pale, highly friable, and super prone to tearing. That micro-tearing is what causes the bleeding and the severe pain people report.
Okay, so knowing that the tissue is literally starving and fusing together and inviting bacterial infections, we have to talk about the massive gap in treatment here. Because one of the BSSM statements notes that 70 to 84% of postmenopausal women experience GSM symptoms.
It's a huge number.
But yet, only 7% actually receive treatment. I mean, if 84% of people had their knee cartilage just dissolving, the healthcare system would be totally overwhelmed. Why is there a 77% gap here?
It's tragic, really. The clinical data points to this catastrophic two-way communication breakdown. Only about 25% of women ever volunteer this information to their doctor.
Wow, just 25%.
Yeah. There is this profound stigma and embarrassment, which is combined with a pervasive societal belief that, pain and bodily deterioration are just your lot in life as you age.
Just deal with it, essentially.
Exactly. And then on the clinician side, 70% of healthcare professionals admit they rarely, if ever, ask patients about painful sex or vaginal discomfort.
We've basically normalized the suffering to the point that nobody even asks the question.
Which is particularly dangerous with GSM, because unlike hot flushes, which are, a vasomotor symptom that can eventually burn out and just improve on their own, GSM does not improve spontaneously.
It doesn't.
No, it is a chronic, progressive anatomical deterioration. If you don't treat it, that cellular collapse we just talked about, it just keeps getting worse.
Okay, well, here's where it gets really interesting. Because if the root of this is starving fibroblasts and a lack of estrogen, we need to address a major misconception. The acronym GSM uses the word menopause. So people naturally assume this is only an issue for older women having painful sex, but if the trigger is just low estrogen, this could totally happen at other stages of life, couldn't it?
Absolutely. The physiological trigger is strictly low estrogen, regardless of how old you are. The sources outline several scenarios that induce a hypoestrogenic state. Breastfeeding is a really major one.
Of course.
Yeah. The hormones required for lactation naturally suppress your estrogen production, which can cause severe, albeit temporary, GSM symptoms. Certain progestogen-only contraceptives can do it. Even everyday medications you probably have in your bathroom cabinet right now, like antihistamines for allergies, oral decongestants, or even certain antidepressants, they can dry out these mucous membranes and trigger symptoms.
Which means this impacts daily life far beyond the bedroom. I mean, if you've lost that collagen and the tissue is hyalinizing, simple friction must be awful.
It is. It affects women who are not sexually active whatsoever. Just the basic friction of normal underwear against that thinned, friable skin can cause micro tears. The sources highlight patients who find walking, sitting at a desk all day, or riding a bicycle to be just agonizing.
Gosh. I want to circle back to the urinary tract too, because you mentioned the urethra and the bladder trigone are also packed with these estrogen receptors.
Right. They actually share the exact same embryological origin as the lower portion of the vagina, meaning they are just as dependent on estrogen to survive. So when estrogen drops, the tissue lining the urethra thins out and the smooth muscle weakens.
And what happens then?
The urethral sphincter essentially loses its tight seal.
Oh, and because we established that the vaginal pH has neutralized and E. coli has moved in, that weakened seal makes it incredibly easy for bacteria to just travel right up into the bladder.
That is the exact mechanism behind recurrent UTIs in this demographic.
Right.
But consider what happens in the actual clinic, right? A patient comes in with burning urination and urgency.
Right. Classic UTI symptoms.
Exactly. The doctor runs a quick dipstick test, sees bacteria, and prescribes an antibiotic. Now, the antibiotic clears the E. coli temporarily, but it does absolutely nothing to fix the thin urethra or the neutral pH.
Right. The environment is still broken.
Exactly. So a month later, the E. coli just returns. The patient gets trapped in this endless cycle of antibiotics, often misdiagnosed as having a standard bladder infection, when the actual root cause is untreated GSM.
That is so frustrating. Okay, so if the problem is this widespread ecological and structural collapse, how do we actually wake those cells up? Like, can an over-the-counter option do that, or do we really need to replace the missing fuel? The clinical guidelines lay out this treatment ladder, starting with non-hormonal options like lubricants and moisturizers. But the sources are very strict about the difference between those two.
Yes, because they serve completely different biomechanical purposes. Lubricants like WS-WB or Silk, they're acute solutions. They are designed solely to reduce friction during sexual activity or to make medical exams, like a cervical screening, less painful.
Right, so a lubricant is like applying lip gloss right before you need it for a specific event.
Yeah.
But a moisturizer is more like your daily face cream that actually sinks in and changes the hydration of your skin over time.
That's exactly it. Medical-grade moisturizers like Yes's VM or Replens, they're bioadhesive. The molecules are actually engineered to cross-link with the mucin and epithelial cells on the vaginal wall.
Oh, wow, so they stick to it.
They latch onto the tissue and they physically trap water inside. And most importantly, high-quality moisturizers are formulated to be slightly acidic.
Ah, to fix the pH.
Yes, which helps lower the pH back down, making the environment hostile to E. coli all over again. They're meant to be used continuously, usually every 3 days or so, regardless of whether you're sexually active.
So they manage the environment and the hydration. But they have a limitation, don't they? I mean, they aren't replacing the estrogen.
Right. Moisturizers are fantastic for symptom management, but they cannot reverse the underlying anatomical changes. They can't command those dormant fibroblasts to start synthesizing new collagen. To rebuild the tissue thickness and restore the rugae, you really have to reintroduce the missing hormone.
Which brings us to localized hormones. And I know if you are listening to this and thinking, there is no way I am putting estrogen near my body after everything I've read about breast cancer risks, you are definitely not alone. That fear is incredibly common. How do the clinical guidelines from, like, NICE address this?
The guidelines draw a very hard, definitive line between systemic hormone replacement therapy, so HRT, and local vaginal estrogen.
Okay, what's the difference?
Systemic HRT involves pills or patches that flood your entire bloodstream with estrogen to treat systemic symptoms, like hot flushes or bone density loss. But we are talking about local therapy. These are tiny tablets called pessaries, or creams, or flexible rings that are inserted directly into the vagina.
But how localized is it really? Doesn't it still enter the bloodstream eventually?
The absorption is extremely minimal. It acts directly on the local tissue to revascularize the area and bring back that collagen. To put it in perspective, one of the sources actually calculates that using a low-dose vaginal estrogen tablet twice a week for an entire year,
Okay.
exposes your systemic bloodstream to roughly the same amount of estrogen as taking just one single systemic HRT pill.
Wait, really? One pill's worth spread over 365 days?
Yes, it's an incredibly small microdose. And because the systemic absorption is so negligible, the clinical guidelines state that you do not need to take a progestogen alongside it to protect the lining of your womb, which is a very strict requirement if you're on systemic HRT.
Well, that's a huge difference.
It is. Local estrogen is deemed totally safe for long-term, indefinite use.
Good to know. Now, the sources also mention another local option, DHEA, which is prescribed as Intra-Rosa. But DHEA isn't estrogen. The sources say the body converts it. How does that actually work?
So DHEA is a precursor hormone. You can kind of think of it as raw, inert building material. You insert the DHEA pessary, and the cells in the vaginal wall just absorb it.
Okay.
Those specific cells contain enzymes aromatase and reductases that essentially chop up the DHEA molecule and rebuild it into active estradiol and testosterone right there inside the
Think about the cell itself.
Yes, it's an intracellular process, and that testosterone is really vital for maintaining the muscle health and connective tissue of the pelvic floor. And again, this all happens locally without significantly raising hormone levels in your blood.
Okay, but what happens when a patient simply cannot use these localized treatments? Say we have a patient in a care home who has severe arthritis in her hands, and she just can't manipulate a tiny tablet applicator. Or maybe a dementia patient suffering from recurrent UTIs who just won't tolerate a vaginal cream. What then?
Well, medical engineering has actually provided an alternative for those exact scenarios. The guidelines highlight an oral medication called ospemifene.
Ospemifene.
Right. It is a daily pill, but it is not estrogen. It belongs to a class of drugs called SERM-selective estrogen receptor modulators.
Wait, how can one pill be selective? I mean, once I swallow it, it enters my digestive tract and goes into my bloodstream everywhere. How does the exact same molecule know to act differently in the vagina versus, say, the breast?
It is so clever. It comes down to the shape of the molecule and the environment of the specific organ. Think of the estrogen receptor like a lock and ospemifene as the key.
Okay, tracking.
When the ospemifene key enters the lock in the vaginal tissue, it interacts with specific co-activator proteins present in the vagina. That combination turns the machine on. It acts as an agonist, thickening the tissue and basically clearing up the GSM symptoms.
Right.
But when that exact same key enters the lock in the breast tissue or the lining of the womb, the co-proteins there are different. So the key fits in the lock, but it jams.
Oh, wow.
Yeah, it acts as an antagonist, actually blocking estrogenic activity.
That is fascinating.
Yeah.
So the local tissue environment itself dictates how the drug behaves.
Exactly. It provides the vaginal benefits of estrogen from a simple daily pill without stimulating breast tissue at all.
Well, mentioning breast tissue brings us to perhaps the most sensitive patient population in these guidelines, which is breast cancer survivors. Many oncology treatments are specifically designed to just starve the body of estrogen to prevent cancer recurrence.
Right.
Chemotherapy can induce early menopause, and then the subsequent hormone blockers cause really profound, severe GSM. For decades, these patients were told they just had to endure the pain and the UTIs. Are local treatments actually safe for them?
It requires careful nuance, and it depends entirely on the mechanism of their specific cancer drug. The sources essentially break this down into two main categories.
Okay.
First, you have patients taking tamoxifen. Now, tamoxifen is actually a SERM itself. It circulates systemically, sits on the estrogen receptors in the breast tissue, and blocks them.
Like the jammed key you just mentioned.
Exactly. And because tamoxifen acts as a systemic shield, blocking receptors throughout the body, the guidelines indicate it is often considered safe for these patients to use local vaginal estrogen.
Because the tamoxifen is already blocking it anyway.
Right. The tamoxifen basically counteracts any trace amounts of estrogen that might manage to enter the bloodstream from the vaginal cream.
Okay, so tamoxifen blocks the systemic receptors, allowing you to treat the local vaginal issue pretty safely. But what about the other class of drugs, the aromatase inhibitors?
So drugs like letrozole or anastrozole, they operate on a completely different mechanism. They do not block receptors. Instead, they shut down the body's enzyme production to stop peripheral tissues from manufacturing any estrogen at all. The clinical goal there is to drive the patient's systemic estrogen levels down to absolute zero.
If the goal is absolute zero, then even that tiny microdose from a local vaginal cream suddenly becomes a real problem.
Exactly. Oncologists worry that even minimal absorption from a vaginal estrogen product could compromise the really strict suppression required by an aromatase inhibitor. Therefore, vaginal estrogen is generally avoided for those patients.
So if hormone replacement is totally off the table and moisturizers only do so much, what are the options for patients on aromatase inhibitors?
Well, the consensus statements do discuss some emerging physical therapies, specifically fractional CO2 or erbium lasers.
Wait, lasers utilized internally.
Yes. The mechanism there relies on neocollagenesis.
Neocollagenesis, so literally the creation of new collagen. It's a
Right.
localized trauma response.
Precisely. It's very similar to the way dermatologists use microneedling on the face. The laser applies controlled microscopic thermal energy to the vaginal wall, creating these tiny columns of damage.
Right, triggering the healing.
Yeah, the body registers this microtrauma and rushes repair cells to the area. It wakes up those dormant fibroblasts we talked about earlier, forcing them to produce brand new collagen and form new blood vessels to heal the quote-unquote injury.
So it physically thickens and restructures the tissue entirely without the use of any hormones.
Exactly. It leverages the body's own healing cascade to repair the atrophy. Now, it shows immense promise for patients who absolutely cannot use estrogen. However, the British Menopause Society does caution that we still lack robust long-term data on safety and efficacy for it. And these treatments are generally private, quite expensive, and not widely available on the NHS just yet.
Right, still early days.
Yeah.
Well, stepping back and looking at the vast mechanics we've explored today. So what does this all mean? The takeaway really is that vaginal dryness is just a woefully inadequate term. It is merely the surface symptom of a much deeper structural and ecological breakdown.
Absolutely.
When the estrogen fuel drops, the tissue literally starves, loses its elasticity, alters its pH, and invites infection. A cascade that is properly identified as Genitourinary Syndrome of Menopause, or GSM.
A cascade that is measurable, physical, and importantly, highly treatable with tools ranging from bioadhesive moisturizers to localized hormone microdoses.
Yeah. The failure isn't a lack of medical solutions. The failure is that 84% of people experience this structural collapse.
Yeah.
But communication barriers and outdated terminology keep 77% of them from ever getting any relief.
Exactly. And as we wrap up this analysis, I want to leave you with a broader physiological question to maybe mull over. We've just mapped out how a localized drop in estrogen and testosterone causes the physical tissues of the bladder, the urethra, and the pelvic floor to completely degrade and weaken. Right. Hormone receptors are that critical to the structural integrity of our muscles and connective tissues. How many other physical ailments that we just simply accept as the inevitable wear and tear of aging, like, say, mild incontinence or loss of mobility, or even chronic pelvic pain, are actually just localized, highly treatable hormone deficiencies?
Oh, wow. That really challenges the entire framework of how we view aging and structural decline. I mean, if we can understand the mechanism, we can usually find a way to fix it. Thank you so much for joining us on this deep dive. Take this breakdown, look past the surface and share this knowledge with those who might be navigating these exact medical hurdles. And as always, remember to keep asking questions.